Hi, I'm Dr. Sohanpal. I'm a GP at Wateringbury Surgery, and I practice looking at a wide range of conditions, but specifically today about asthma. I see a lot of presentation of acute asthma in my clinic, and I use the FeNO a lot to try and diagnose it. I think the key thing about FeNO that makes it important is the speed at which you can get an answer. Sometimes historical testing for asthma can take anything from weeks to sometimes months before you have a diagnosis, whereas with the FeNO it's a matter of seconds to minutes on the same day often. So I think that makes it very important, saving time for healthcare professionals and services, as well as improving times to therapy for our patients and getting them better from their symptoms. It's a good question. I'm not sure exactly what the data is about monitoring with FeNO and how it can be used from a monitoring purpose. For me as a clinician, it's more a diagnostic tool, so I would just use it the once. Or I might use it again at a different time if a patient presents when their symptoms aren't acute, and if I thought there was a high index of suspicion for asthma. So generally speaking, I use it once at the point of care, but I know that in our practice nurses do use it more frequently as a monitoring tool. I think the testing itself is more useful diagnostically for me. In terms of monitoring, I can see that if a patient has a persistently raised FeNO level, that might guide that their asthma treatment needs escalating, especially if they're symptomatic. So you would use it as an added data point with their clinical symptoms to try and guide the treatment for asthma, escalating their treatment from, say, short-acting beta agonist only to something that has a steroid in it and a long-acting version of a beta agonist, and so on and so forth. In terms of how accurate it is, I'm not sure on exactly the data, but in terms of, for me, again, it comes down to the swiftness that you can get a response. So if I were to refer somebody for reversible spirometry, that could be anything from 6 to 8 weeks before they actually have that test, and a couple more weeks before I get the result, and then I'm able to review the patient. The problem with testing asthma, especially in your mild population, is that they might have a flare-up of their symptoms, which then might resolve by the time they actually have the test, and it might not show at that time that they've got asthma. Whereas if you can test somebody when they're presenting to you on the front lines with something that will give you an answer there and then, you're more likely to get a positive result, for example on the FeNO, and that can get them onto treatment more quickly. It can help diagnose that somebody might be asthmatic or having an asthma flare-up at the time that you see them. Specifically for my use, I would see a patient presenting to me with symptoms. It's rare somebody would go to see a GP because they thought they might have asthma when they actually haven't got symptoms at that time. So where I would use the testing is more at the moment where they come in, where they've been short of breath and wheezing and chest tight, usually for several weeks because it hasn't resolved over a 5 to 6 week period. That tends to be about when they come in to see me. And that's when you would do a FeNO test to say, okay, well, you might be asthmatic, and this test has now shown that you probably are because you've self-selected that population from what's presenting to you, and then you'd go from there. It's certainly made me more, it's increased my index of suspicion for asthma now that I know I've got a test that I can do very quickly to get an answer. Whereas before, you might have a wide differential in your mind about why a patient has come to see you and think about all the potential causes for their symptoms. Now that I have access to something like a FeNO machine where I can test it pretty quickly, it's increased my index of suspicion, and therefore it's also increased the number of people that I found who actually do have asthma, because it's narrowed down that diagnostic process very quickly just by being available. Well, there are other conditions potentially that might cause somebody to have a raised FeNO level. So it's about being aware of those instances where the test might give you a false positive. That's more on the clinical side, I suppose. Possibly. I was just having a discussion earlier about the possibility of the fact that COPD can sometimes raise FeNO levels, apparently, something I need to read a bit more on. So your smokers potentially could have a crossover syndrome, and so you might pick up a COPD with FeNO and think it's asthma. But in terms of in terms of otherwise, I don't think so. No, I think it's quite a useful test as long as it's used appropriately by the clinician for the appropriate clinical scenarios. I really don't know, to be honest. It really depends on how widely known the test is to our patients. Most of my patients have never heard of FeNO or nitric oxide and aren't aware of the fact that it can be tested at point of care. So that would be more about making it more widely appreciated by the general public that this test exists, and nitric oxide is part of the asthma inflammatory process. That's all down to education, I think.
Okay, well that concludes our questions. Your insights are very valuable, so we do really appreciate you taking the time. Thank you very much.
It's a pleasure, thank you.